So let's introduce you to our live model, DJ Kramer. Hi, DJ.
Hi.
Hi, welcome, and thank you so much for being willing to be our demonstration person for our pregnancy course here. So first of all, how many pregnancies have you had?
This is my second.
This is your second. So, and how far along are you?
I'm 35 weeks.
So you're obviously into your third trimester. And how's this pregnancy been for you?
It's been good and healthy.
And what types of, because of course we'll be focusing on numerous things, and as I talked about in the lecture, with pregnancy you have musculoskeletal issues, but you also have circulatory issues and respiratory issues that you want to try and optimize. What types of complaints or problems or issues or discomforts, I guess I should say, have you had through this pregnancy?
I've had a lot of sciatic pain and also a lot of discomfort in my hips.
Okay.
And occasional low back pains, aches and pains all over.
Right. So, so the hips, the low back, and then also sciatica. So when you say sciatica, what happens for you?
I'll get a sharp pain, usually in the glute, that travels all the way down my leg on the side.
Okay. So it goes down the side of the leg and it goes past the knee?
Sometimes. It makes walking very uncomfortable.
Very uncomfortable. Okay. And then you had mentioned before, I brought you on camera, something about a number of friends and a blog. Could you tell?
Yeah, on my mommy blog, I constantly hear all the pregnant women complaining of the same issues, or more extreme versions with their tailbones coming out of place and a lot of discomfort in the backs and hips as well. So it's very, very common.
So at this time, let's go into our demonstration. So what I'd like to start with is to look posturally. When I start out with any patient in my office, I'm going to start by first looking at their posture and looking for asymmetry. Remember our acronym TART, T-A-R-T, are the things you're looking for in order to diagnose somatic dysfunction. So the first T for tissue texture changes, A for asymmetry, R for restriction in range of motion, and the final T for tenderness. So if we remember TART and we start out general and look at the overall posture, and then we can start looking regionally and even more segmentally. So let's start out with DJ looking at her lateral posture, specifically in relation to the fact that we're focusing on the pregnant patient, because I'd like to point out some aspects of what a growing fetus in the abdomen will do to the posture to bring out the very common complaints of low back pain, sciatica, hip pain, groin or pelvic pain. So let's take a look. So looking at DJ's just standing comfortably side and looking at her lateral posture, first of all, I'd like you to take in the curve of the low back and the aspect of the pelvis. So first of all, you would notice that she has an increased lumbar lordosis as a result of the growing fetus and the abdomen with the protuberant abdomen coming out and over the pelvis, drawing the pelvis forward. So you get an anterior tilt to the pelvis and an increased lumbar lordosis. These are the two most common aspects of that any physiology book would focus on with the pregnant patient. But also what you'll notice then is you also end up with a bit of an increased kyphosis in the thoracic region and an increased lordosis in the cervical region. And then also now, so therefore the transition areas are going to be very important for you to be thinking about when you treat any patient, but particularly the pregnant patient. So the cervical thoracic junction, the thoracolumbar junction, and the lumbosacral junction, which we'll point out as we start to treat. Also, there are many, many soft tissues that get strained in pregnancy. Obviously, the abdominal muscles are getting extremely stretched as the growing fetus gets larger and larger and larger. And remember, DJ is in her third trimester. The other thing is the quadratus lumborum muscles and the other paraspinal muscles in the low back and through the spine are working very hard to counterbalance the tilting pelvis and the abdomen drawing the whole low back forward. The gluteal muscles are all being stretched. The hamstrings are all being stretched. The iliopsoas muscle is working very hard from the front of the lumbar spine down into the pelvis to the hips to try and counterbalance that anterior tilted pelvis. Also, think about the diaphragm with the aspects of respiration. As you see, the growing fetus is coming right up into the diaphragm, which is going to cause a problem for its function, but also the anterior-posterior diameter of the abdomen as well as the thoracic cage is increasing, which is also decreasing the transverse diameter, and the lumbar paraspinal muscles are being pulled on. So remember that the diaphragm attaches with its crura at around L1, L2. And so, again, that thoracolumbar junction and the effects it's going to have on restricting respiration. And then moving up into the upper body, again, this increased kyphosis and a little bit of the rolled shoulders. So the lower trapezius are being strained, the levator scapular muscles are being strained, the pectoralis major and minor muscles are being strained. And so all of these areas need to be kept in consideration with the pregnant patient as you start to treat. Okay, now I'd like to take a look at DJ's posture posteriorly. And where this comes in is I look at every patient, whether they're pregnant, whether male, female, old, young. One of the biggest things I would start out with is this next presentation I'm going to give. So now, the idea of integrating all of the techniques and how would I start out with a patient in taking a look at their posture and again looking for asymmetries to know what are the types of things I want to try and help balance to take away their pain. Because remember, the foundation of osteopathy is structure, function. If there's imbalance in the structure, there's going to be imbalance in the function, and that's going to lead to pain. So let's take a look. So now with DJ with her back to us, what I would usually take a look at right off the bat with someone standing in this position is their shoulders. And if you look at her shoulders, and if I put my hands on her shoulders, her right shoulder is higher than her left. And if what helps you also with this is to then drop your thumbs right under the inferior angles of the scapulae, and you'll notice that consistent with this is that the right scapula is elevated and the left scapula is inferior in relation. So to show you that again and to look at my thumbs, you'll see that my right thumb, her inferior scapular angle is superior and her left inferior scapular angle is inferior. So it's showing an asymmetry through her thorax. Now again, she has an increased bit of a lordosis, and then what I would do is drop down and take a look at the iliac crests. And you come in with your hands as shelf-like as possible onto the iliac crest with your thumbs straight out. And now you look at that and you'll notice that the right iliac crest is a little higher with her standing than her left iliac crest. And then you would drop down with your thumbs and find the posterior superior iliac spines, the PSISs. And this is where you're going to want to do a standing flexion test. So my thumbs are right underneath the PSISs. I would ask the patient, go ahead DJ and bring your chin towards your chest and then start to just curl forward and down like you were going to go touch your toes. And if you watch my thumbs, my right thumb has started to initiate movement upward and my left thumb has not essentially moved. DJ, come on back up a moment. And if it's all right, I'm going to have you do that one more time. So again, iliac crests, thumbs under the PSISs so you know you're in the same place on both sides. And then DJ, chin towards your chest and curl forward and down. And people on the camera, you'll notice my right thumb rises, my left thumb does not. Come on back up. What that's telling us is that her right ilia is restricted in motion on the sacrum. So her right iliosacral joint is most likely the culprit in some of the problems she's having. Which leg do you get your pain down, DJ?
Usually the left.
Actually, it's usually the left. And that's not uncommon to find, that your dysfunction is on one side, but the pain is actually on the other. That is not uncommon. But we want to remember that her standing flexion test was positive on the right. I'd like to take a minute and use Stan. Remember, standard Stan from our other courses is our other demonstration model, and he is very easy to work with. But what we're going to do is focus on, and what I'd like to try and demonstrate by using Stan at this moment is you're looking at his spine and you're looking at him posteriorly, and I've sort of tried to have him seated on the table because I'm going to bring DJ back in and have her seated on the table. And what I'm trying to focus on right now and demonstrate for you is, if you'll notice, the spinous processes of the vertebrae right down the middle of the spine, through all the cervicals, thorax, lumbar spine, down right to the sacrum and the tailbone, and they even have, the tailbone of the sacrum even has little spinous processes there. If you come about a good finger or two breaths out, you'll notice, especially in the lumbar region, very prominent transverse processes on either side of the vertebrae. And then you come up into the thorax and you'll notice the transverse processes, but you'll also notice they attach directly to the ribs. And then you come up into the cervical spine and you don't notice such prominent transverse processes, but these are called lateral masses, or the articular pillars, which is what we would be feeling in the cervical spine. So when I bring DJ out in a moment and I have her seated on the table with her back to you and I start palpating on either side of the spinous processes, what I'm feeling for is the transverse processes on either side. So I'll be palpating these areas here. And what I'm feeling for when I do that is one side more posterior or prominent and the other side deep. So Douglas, I don't know if you can show this with my hands, but the idea that if I palpate and one side is prominent and posterior and the other side my fingers go in deeper, then that is telling me that that vertebrae at that level is rotated. And you'll notice that if it's prominent on this left side of the patient, deep on this right side of the patient, that's telling me that the anterior surface of that vertebrae is rotated to the left. Okay? So that is why we would be doing these things, and that's what I'm feeling for on the patient. Now remember also, you can have type 1 curves, which means you could have multiple vertebrae involved, such as 5 different vertebrae. Let's say T2, T3, T4, and T5 all get side bent to the left. And if that happens, you need to remember that type 1 curves side bend in one direction and rotate the opposite direction. So in this particular example, if T1, T2, T3, and T4 are all side bent to the left, they would then be rotated to the right. And therefore, the prominent transverse processes would be on the right side. So that's one way you could be looking for a somatic dysfunction. You also could be checking out these transverse processes all the way down, and you might find only one transverse process prominent, meaning posterior, in relation to the one above and the one below. If only one vertebrae is found that way, remember that is a type 2 somatic dysfunction, where only one vertebrae in relation to the vertebrae below it has, let's say, side bent in one direction. And remember that with type 2 somatic dysfunctions, the side bending and the rotation will happen in the same direction. Another thing that differentiates a type 1 curve or a type 1 somatic dysfunction from a type 2 somatic dysfunction, remember, is that a type 1 somatic dysfunction includes multiple vertebrae. They side bend in one direction, they rotate the opposite direction, but all of that happens in neutral, meaning there's no flexion or extension involved in the spine. You will find them with the patient in this neutral position. When you are looking for a type 2 somatic dysfunction, remember that that will also have either flexion or extension involved. So the vertebrae will either be flexed or extended, side bent and rotated in the same direction. So these are the types of somatic things that we're going to be watching for and palpating for in the spine with the patient seated with their back to us. And we're going to regionally look, particularly at the thoracic spine and the lumbar spine with the patient seated, because these Fryet's laws of somatic dysfunction, such as type 1 and type 2 somatic dysfunctions, happen in the thoracic and the lumbar spine. The cervical spine does not follow Fryet's laws. So now let's see if we bring DJ back in, and we'll take a look. But also, one other point I'd like to make is we took a look at the standing flexion test with DJ while she was standing before. But another test, in order to focus back again, remember the standing flexion test focused on how the ilium moves on the sacrum. But the seated flexion test, which I'll also do with DJ when I bring her back in a moment, is another test to try and help us determine which side might be the problem. And we want to focus also on how the sacrum moves on the ilium. So you'll notice when a patient is seated, and Stan shows us very well here, that he is sitting right on his ischial tuberosities down here. So you see his ischial tuberosities right down on the table. So that is causing his innominates, because the ischium, the ilium, and the pube fuse together to form the entire innominates. And so after 25 or so, 20 years old, 25 years old, our three pelvic bones fuse together to form the two innominates in the two sides of our pelvis. When we sit down, we're sitting on the ischium, or the ischial tuberosities, and so the innominates are restricted in their motion. So when I have the patient then flex forward, as I'm moving Stan forward, now remember he's all screwed together, so this isn't realistic, but the idea is when he starts to move forward, the innominates are restricted in their motion, but the sacrum can move. And so whichever side, when I show this with DJ, I'll have my thumbs underneath the PSISs in the same way I did in the demonstration with DJ standing. I'll have my thumbs here, and when she goes forward, the side that rises, if one does, tells me that the sacrum is restricted on the ilium on that side. So we'll bring DJ back now, and let's take a look at all this stuff. So now that I've brought our live model, DJ, back, let's take a look at her back with her sitting in this position that we had Stan in a moment ago. And let's take a look again at her shoulder heights. So if I'm going to bring my hands in and lay them on her shoulders, you notice, and I'm trying to stay out of the way so you folks can see, but you'll notice that her right shoulder is higher than her left. And again, if I bring my thumbs underneath the inferior angles of the scapula, you'll notice that's consistent. Her right shoulder is elevated and her left shoulder complex is inferior. Now, if I come in and palpate for the spinous processes of the spine, so now of course we have to feel through all the soft tissues. Stan, it was nice and easy, you could see the spinous processes, but with live models it's not quite so simple. And then once you find the spinous processes, just move again out laterally and feel for the transverse processes and walk your way down, feeling and seeing what you see. And with DJ, if you'll notice, up here at about T2, we have my right thumb is deeper than my left thumb. The tissue on the right is deep and allowing my thumb to go protrude into the soft tissue, whereas my left thumb is not going as deep into the tissue. And I'm not pushing really hard on either side. And then you go down to T3, and that's the same situation. T4, the same situation. And walking down the thoracic spine, you will notice that my right thumb keeps going deeper into the tissues than my left. DJ pretty much throughout her entire thoracic spine, from T2 to all the way down to about T10 or 11, has a rotation to the left, meaning these transverse processes are prominent and these transverse processes are deep. So the vertebrae are rotating to the left. Now, if that's so, her entire thoracic spine should prefer to side bend in the opposite direction. So let's take a look at that. If I put my hands up on her shoulders and I press down to try and get the thoracic spine to side bend, and remember the thoracic spine doesn't really like to side bend. Its preferable motion, or its motion that is most free, is rotation. But it can side bend some. And so when I push down on this right side versus the left, look at that. When I try and side bend her left side, she does not want to do that. Whereas when I side bend her right, still it doesn't do it a lot, but it definitely does it much more freely. So we have a somatic dysfunction in DJ in which her T, let's say T2, all the way down to T10 or 11 is rotated to the left and side bent to the right. Okay? So that's something we will, if we want to, let's take the time right now and treat that, because that's usually how I work with a patient. I would look at them standing and see the postural asymmetries. Then I would have them and do the standing flexion test. Then I would have them seated and I would evaluate their thoracic spine and their ribs. So let's treat this now. Now many times I will use the still technique in this situation. So let me demonstrate how that would be done. First of all, if DJ has a type 1 curve all the way through the entire thorax from T2 all the way to T10 or 11, I'm going to get in the middle at the peak of that curve at about T5, T6. So right about this area here. And I'm going to get on those transverse processes. Now, I'm going to switch sides on you folks because I need to get on this side to maintain my listening fingers or my feeling fingers and palpating fingers at the peak of the curve. I'm going to bring my other arm around the shoulders to do a still technique on this curve. So I'm going to take the curve where it wants to go. I'm going to rotate her thoracic spine to the left where it wants to go down till I feel this level, and I'm going to side bend her to the right, and I'm going to keep her in neutral. And then I'm going to apply a force vector from both shoulders down to this area till the tissue feels more relaxed. And as I've done that, I am then going to take her from the position of ease with a force vector around the other way, maintaining the force vector to treat this curve. So I'm going to try that now by rotating her to the other side and opposing. So there, I took her from rotated left, side bent right, rotated around to the right, and side bent her to the left. Let's see if it had an effect. So now if you look at her shoulders and her inferior angles of her scapulae, they are much more even. And when I put my thumbs on her transverse processes, they are much more even. So we have just treated her thoracic spine, which had a type 1 curve. The other thing that, remember, affects the pregnant patient is respiration, and we want to optimize every aspect of respiration we can. So also with the patient seated, whether they were pregnant or not, I'm also going to focus on their ribs. So now, what we just focused on before was the spinous processes, transverse processes. If I come out another distance out to the sides, you'll notice I'll be on the rib angles, out in this direction, out here. So now if I ask DJ to take a breath in and out, look at that. You notice my right thumb moved. Do that again for us, DJ. The right thumb is moving up and down. The left is not moving at all. If I go to the next rib angle, breath again for us, DJ. Again, right is moving, left is not. And one more time. Breath in and out. And that one's not moving either. And again, breath in, breath out. So her left rib cage, the second, third, fourth, fifth, sixth ribs on this left side all seem to be restricted. The other thing is that when I feel these rib angles, these left-sided rib angles again seem more prominent. They seem more posterior. And when the rib angles feel more posterior, those ribs are restricted in stuck down in exhalation. So they're sticking out. Therefore, in order to treat this posterior rib cage, if I think that they're exhaled ribs, then based on our thorax and rib series and course, if a rib is stuck in exhalation, which rib, and there's a group of ribs, which rib do we want to treat in order to possibly have an effect on all of them? It would be the most superior restricted rib, because if we move that rib and that one moves freely, the ones below it may also possibly now move freely. So again, I'm going to switch over to DJ's other side and see if we can demonstrate how to treat this. So we're going to start on this second rib here, on the rib angle. I'm going to ask DJ to raise her arm up in front of her and bend her elbow across her chest. So the patient would start out in that position. But this rib is exhaled, therefore, and this rib angle is posterior. So I want to bring this arm to bring this rib posterior. So I'm going to bring the arm around posterior, and you notice that's bringing the rib with it. And I'm feeling the tissue here that it's relaxed. I'm now going to apply a force vector. And again, I'm not applying a force vector through the arm. It'll go there. I'm applying a force vector in my mind between this hand and my thumb. And then from there, using the still technique, which is what we're demonstrating, I'm applying pressure. And we're going to bring this arm around front, which will bring the rib around front. And then let it drop down. And now, DJ, take a breath in and out for us again. Let me switch back over so I can get my thumbs where I had them before. Do that again, please. Okay, the left thumb's still not moving quite yet. Let's try this for one more rib lower. Bring this arm up. Bend the elbow across your chest. We're going to bring it around back. Little pressure here, and we're going to bring that arm around front. And down. And now breath in and out for us. Good. And again. And now you see we're getting better motion out of that left rib. One more time, DJ. Breath in and out. And down. And I'm going to drop to a lower rib. Do that again for us. And you'll notice now the ribs are moving. So what I've demonstrated so far is posturally looking at the shoulders to help us look for asymmetry. And that asymmetry is usually going to be coming from the thoracic spine and the rib cage. And in this seated position, to integrate these techniques, is how I would now examine the thoracic spine, the rib cage, and treat it. And what you've seen me use up till now, and in this demonstration, was the still technique. The other thing I would like to move towards now and demonstrate is the seated flexion test. So DJ, what I'd like you to do is just scooch forward to the edge of the table so your feet are down, actually touching the floor. Yes, but you're still seated on the table just like that. So you notice now her ischial tuberosities are seated on the table. And I would like to do the seated flexion test. So I'm going to come on in with my hands onto the iliac crests. I'm going to drop with my thumbs onto the posterior superior iliac spines, and I need to find those little knobs, get my thumb underneath, and then just like we did with the standing flexion test, but now her ischiums are on the table, I'm going to ask DJ to drop her chin towards her chest and then curl forward and down like she's bringing her head towards her knees. And now you'll notice our left side is restricted. It moved up. You can come on back up, DJ. The side that moves is the side that's restricted because it's stuck. The sacrum is restricted on the ilium in this case. So DJ, put your chin towards your chest and curl forward one more time for me, and you'll notice that the left side moves. So come on back up. So this is a seated flexion test, positive on the left, which is telling us that the sacrum is restricted on the left ilium.